The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. We're fortunate this month to be talking to Dr. Mike Moss, who is the medical director of the Utah Poison Control Center. Thanks for joining us, Mike.
Thanks for having me on the podcast.
Any disclosures that you've developed in the past week?
No, nothing to disclose.
Let's dive in. So there are several things that I think we all recognize that we try to do some preventive measures, but let's talk about some of these things. Remind us why acetaminophen is a thing.
Yeah, acetaminophen, right? This is one of our most bread and butter topics for us in the poison center world, something that I don't go a day without thinking of a couple times over and over. Acetaminophen's in everything, right? Of course, it's in Tylenol products. It's in all sorts of cough and cold things. Every time a kid's teething, got a fever, some aches and pains, we're doing some acetaminophen. There is pretty good safety margin, right, with acetaminophen, but we know it can be hepatotoxic and lead to liver failure, transplant, or death. And it's one of these things that can be susceptible to some dosing errors of doing a liquid medication, trying to measure something out. For our adolescents, it's around the house and easily accessible, so a very common medication they might take in a self-harm attempt. And so this is something we see all the time. It's ubiquitous, potentially dangerous, though very safe in normal dosing. And then a lot of people aren't too familiar with it, but fortunately, we've got decades of research of how to handle it and also very effective antidotes.
Tell us about those. So for one thing, tell us about the parameters that we should pay particular attention to, and then tell us a little bit about the treatment.
So for our young children, we usually do okay. If you're doing a 10 milligram per kilo dose or something, acetaminophen, we've got quite a bit of range till we get to something toxic, probably in the range of 200 milligrams per kilo in a single day for a child to get too much. Where we get close to that sometimes is the child is found with the bottle of children's Tylenol that tastes good, and they manage to drink whatever is remaining. And does anyone know how much was in there before? And if they get the entire brand new bottle, then we might get close to the toxic amount, but most of the time we don't. Occasionally, if there's a mix-up of someone is measuring something using just something out of the kitchen as a spoon or tablespoon and not the measuring cup that came with the medication, they may make repeated errors of giving too much of a medication. Fortunately, years ago, we got rid of different concentrations of children's acetaminophen in the United States, where there was infant Tylenol and then there was children's Tylenol. Now there's a standard concentration, so you don't have your kid graduate from one concentration to another, and then you end up doing a different dose and accidentally given too much of the more concentrated one, for instance. Sometimes there'll be multiple caregivers, but it goes from mom to dad to grandparent or babysitter or someone else, and no one knows who did or didn't give a dose, and now everyone's given a dose and didn't recognize that it was too much. So all those things can play into leading to overexposures in our young kids, and then of course in our adolescents, the self-harm attempts, which can quickly get us to toxic amounts. We do have a good way to assess those. We know with decades of experience that exposures of less than 200 milligrams per kilo in a 24-hour period are exceedingly unlikely to lead to toxicity. Not only that, we can be objective and we can measure it, because we never know exactly how much a child got for all of these sorts of things and confusion that might come up. Or maybe they get into the adult extra strength tablets and it doesn't take too many to get into a toxic range. You may recall the Rumac Matthew nomogram, and this is where we're able to measure an acetaminophen concentration, know what time the ingestion occurred, plot that out, measure the amount of acetaminophen in serum, and then say, okay, this falls below the treatment line, and this kid will be totally fine, nothing to do, can go on home. That's pretty common. The vast majority of our little toddler exploratory ingestions do not need treatment. Very few of them even have to go into the ER to get an acetaminophen concentration checked in the first place, and then even fewer require treatment. But if they do, we have a very effective treatment in NAC, or N-acetylcysteine, If we get that medication started within about 8 hours of an ingestion, we have almost 100% efficacy in preventing hepatotoxicity.
Just to put one thing in context, I was doing the math in my head. So the usual recommendation for daily dose of Tylenol when we're dosing by weight is going to be between 10 and 15 per kilo per dose, up to 5 times a day. So that range would be about 50 to 75 if they dosed all of it. If they forgot and gave an extra dose, then we're dealing with 60 to 90. So while we wouldn't, of course, encourage that they push the limits, there's a fair amount of distance between there and 200 per
Yeah,
day.
good amount of range that a single extra dose is going to be okay. If you accidentally double the dose or something, do it once and it's all right. Where we really get into trouble where it's been 2 or 3 days of a repeated dose being too high and someone didn't recognize it, those are very uncommon situations. And most of the time, even though mixing something up once or twice, or both parents gave a dose 15 minutes apart, hey, we're still well within a realm of safety. Someone's welcome to call us all the time. We'll help you with the calculations. Don't feel bad about the calculations, especially our parents at home. And if you're feeling rough on the math yourself, don't worry about it. Our pharmacists on the phones are always happy to crunch the numbers with you.
They're really good at that. And one other question related to that. Sometimes people will ask, and I don't know the answer to this, if you're giving the recommended dose of Tylenol, is there a number of days in a row that you should worry that you're flirting with toxicity?
No, if you're staying within that recommended range, you're going to be just fine. There's a little bit of wiggle room that if you're going above 100 to 150 milligrams per kilo for multiple days, you can start getting in trouble, right? So we start dropping down from that 200 per kilo in one day. And then if it's over, 2 to 3 days and you're flirting with 100 milligrams per kilo every single day for multiple days in excess of what you should have been doing, then there's possibility of getting into trouble, and we'd probably send you in for some labs to check things out. So there's definitely some wiggle room, but you can go ahead if you're paying attention to the dosing amount and the frequency, then things will be just fine. Even for days at a time of a kid with a prolonged febrile illness or something, no big deal.
Very helpful. As you may be aware, our episodes last month had to do with neonatal opioid withdrawal. Tell us about opioids in your practice.
Yeah, opioids are something that are pretty scary for us and kids. We think of all these sort of high risk medications, one pill can kill scenarios. If there's any drug class that poses the biggest risk to both young children and adolescents, it would be opioids for sure. These are the ones that have been responsible for more hospital visits, more deaths than basically any other prescription medication.
And, if somebody is using illicitly obtained opiates or opioids, there's very little control over what the dosage size is. I'm guessing that if a child were to get into that, that could be very tragic.
Yeah, that's huge doses, even for adults. Even for adults with tolerance, it's a huge dose, and then even worse for a young child. As fentanyl has kind of overtaken our illicit opioid market in the United States, that's made things much more difficult. When it was heroin, this is kind of brown, tarry stuff and not something that a kid's necessarily going to eat. But now a lot of the fentanyl on the streets are these fake oxycodone tablets, and it's a blue pill that is just fentanyl. The people on the street all know this, everyone recognizes it. But if someone's bringing that home, really easy for a kid to get into, easy for an adolescent to think, oh, hey, I got these pills from somebody, let's take some pills and get high.
Sure.
And that one single tablet can be a lethal dose multiple times over.
Would it be productive in almost every instance where somebody may have opiates or opioids in their home for any reason to have naloxone around?
Yeah, I think it's a real easy thing to have naloxone. Everyone can get the nasal spray version. It's available with a standing order in the state of Utah. Most all states have some mechanism for you to get free naloxone or really easy access to naloxone without a prescription from a doctor. Around here, you could walk into any pharmacy and ask for it, and the pharmacist can dispense it to you. You could go to the library. You could go to some of our nonprofit organizations and get it for free or for cheap. So if you've got opioids in the house, you've got kids in the house, go ahead and make sure you've got naloxone available.
My wife's a librarian, so hats off to librarians saving lives again. And are there any special considerations with buprenorphine, given that may be something that may be around long term in households?
Yeah, so buprenorphine is fantastic, right? One of the hats I wear is addiction medicine, and I get a lot of patients on Suboxone, and it's life-saving for those patients to get them on Suboxone and buprenorphine. But there's some unique things about buprenorphine that make it really risky in our little kids. Part of it is we're used to buprenorphine having a ceiling for respiratory depression in adults. Patients that are on it don't perceive it as so dangerous because they're not getting high from it. It's not producing an effect like taking even an oxycodone, for instance, as far as maybe the euphoria that might be felt. So people think of it as quite safe. And then a lot of times it comes in these little films or strips. And so someone will get one out of a package and have it set down on a nightstand or on a counter, waiting to take it, or a tablet falls on the ground. And the dose that's in there is enormous for a child. We have gotten used to the fact that it's 4 or 8 milligrams. And what does that number even mean? Well, therapeutic doses of buprenorphine, even in adults for pain that are naive, is in the microgram range of 100 to 200 micrograms. And then imagine what that is if we scale that down to a 10-kilo toddler.
Yeah.
There's probably even something else going on where young children, in particular, are even more sensitive to buprenorphine and for some reason get more respiratory depression than adults would, even at the same dose. And to make that even worse than all of that is the fact that the onset is delayed, even with something that dissolves under the tongue. So all that together says if we have an exposure to buprenorphine in a child, we say we're probably going to need to watch you for 12 hours in an emergency department, even if this kid looks great at 2-4 hours when an adult would be expecting to have effects from it. We need to keep them because there have been cases of fatal respiratory depression in toddlers who get into buprenorphine and are discharged too early, or it was just never recognized because it was something that dissolved and no one knew what happened.
What about clonidine and the other alpha 2 agonists? Some families will have clonidine around even for kids who are taking it for attention issues, impulsivity issues.
And so clonidine is the other one that definitely gives us some
Yep.
trouble because you'll either have that young child themselves that's not on one of the stimulants, or it's the toddler younger sibling of the older child who is on one of those, and our threshold is pretty low for causing some effects. The good thing is the vast majority of these kids do not have anything life-threatening with clonidine or guanfacine. These are alpha-2 agonists. These then decrease sympathetic outflow from the brain. That leads to drowsiness, some bradycardia, some hypotension. It doesn't take much to cause a little bit of bradycardia and a little bit of hypotension. But fortunately, even when these kids are symptomatic, it's sleep it off in an observation unit or an ER overnight, and then they're fine. They might get a little bit of fluids, and they're generally pretty okay. But we do have a fairly low threshold to send children in because the last thing we would want is for them to get really hypotensive and orthostatic and fall or have something else happen in an unmonitored setting at home. So even if we do end up sending a fair number of these kids into the hospital for monitoring, the vast majority of them do just fine with some pretty basic interventions.
What about the other ADD medications, the stimulants?
Yeah, so the stimulants also they will stimulate the child.
Yeah.
And when we have that 18-month-old who gets into a solid dose of an Adderall or one of the others, they can get pretty revved up. It seems that these little kids don't like that stimulation as much as adolescents and adults like abusing the amphetamines. The toddlers seem to hate it. They get really restless and fidgety, and they will be inconsolable and crying and, tachycardic, hypertensive. And sometimes we don't even know what happened. And then someone checks a urine drug screen in an ER in an inconsolable child and says, oops, amphetamines. And yep, you know what? Older siblings on Adderall, and that's what it was. Like I said, not super dangerous, very low risk of having a seizure or severe cardiac effects from that, but might need a little bit of midazolam, a little benzodiazepine to settle them down and stay overnight in the ER. And that threshold is fairly low when we're talking about the toddlers. Are double dose accidents that happen where both parents gave a child their medication. Usually those are pretty well tolerated, not a big deal.
What about beta blockers, calcium channel blockers?
Yeah, classic ones here for being scary, sort of on the one pill can kill list that you might have heard a lecture on or I got at one time. The good thing is that when it is just one pill, it's not too much. The other difficulty with that is some of these, diltiazem, cardizem, some of these come in really big walloping doses for adults who have atrial fibrillation or something, and they're an extended release formulation. And it can mean that we have a kid that has to go in for monitoring overnight. If they do get bradycardia or hypotension, as you might expect, the toxicity is really easy to understand. The reason we use them, and that's what they cause, right? To slow heart rate and decrease blood pressure. That's what happens. The vast majority of these are fine. There have been some notable, very serious cases over the years. The good thing is when a young child gets into 1 or 2 tablets, they're pretty well tolerated, and it would be some mild bradycardia. of course, our suicide attempts in the adolescents can be some of the nastiest overdoses that we have to deal with.
Sure. What about iron?
Yeah, iron is a classic one. Fortunately, these have gone down substantially. Back in the day, 40 plus years ago, iron was a really big deal, and everyone learns it as a prior leading cause of pediatric poisoning deaths from iron, with the classic situation of mom is taking her prenatal vitamins with a bunch of ferrous sulfate. She has a 2-year-old child, and they get into a bottle of these iron tablets, and then the kid has a massive iron overdose and could potentially die. Iron is pretty toxic. One good thing is the toxic amount is a pretty high dose of 60 milligrams per kilo of elemental iron. One ferrous sulfate tablet contains about 60 milligrams. So you need to get about one ferrous sulfate per kilo to get into a systemic toxicity risk. For adults, that's a lot, right? 60 tablets. For a 10-kilo toddler, 10 is a substantial amount to eat, but not impossible. So those can be problematic. Iron is quite toxic, is very irritating, can even lead to melena, hematochezia, hematemesis, some hypotension, some shock, some liver failure. We do have a medication that can chelate and bind that iron called deferoxamine. Very uncommon to have to use in toddlers. Most of these are now suicide attempts is where we run into it. One of the things that has helped us around all the gummies and vitamins is the amount of iron that's in those is very low. And so when we have our toddlers who manage to down a whole bunch of gummy multivitamins that have a small amount of elemental iron, one, the amount of iron is low. And it seems that something about this gummy formulation means that maybe less of that caustic iron is dumped right onto that sensitive gastric mucosa, and they don't absorb quite as much of it. And even if they have some vomiting, because iron is very prone to causing some irritation to the stomach, these kids don't get systemic toxicity and they don't have severe effects and do not die from these iron exposures. So that's one of the benefits of all of these iron gummies. Seem to be fairly non-toxic. I wouldn't say non-toxic. They can cause some symptoms, but not life-threatening.
But less toxic. And you said that it's been less of a problem now than a few decades ago. Is there a reason for that?
Yeah, so there's a couple things. There was a push, right? Pediatricians learned about it, families learned about it, everyone. There's a big sort of public health campaign to say, hey, iron, this isn't just a vitamin, it's not just totally benign. You need to be careful with these. There was a brief time where there was a restriction on the amount of iron that could be sold and even the packaging for that. Those manufacturers sued, and that rule from FDA was overturned like 20 plus years ago, that those drug manufacturers wanted to not have restrictions on their product and wanted people to not be frustrated by having to open up blister packs and things. And we thought, oh, what's going to happen? But it seems that all of the public education won out, and people have recognized that iron is a potentially dangerous medication. And then again, these smaller amounts of iron in the gummy products have made it more safe. So I think it's a big win just from a public education standpoint.
Oh, good. Let's run through some other environmental things. Button batteries.
Yeah, button batteries are all over the place, all sorts of little toys that
Yeah.
have them. You've probably got some remote controls of everything's got a remote these days. And inside that little tiny remote is probably a button battery. The little cover can come off of that battery compartment. And even one that seems, partially discharged or kind of dead could still be problematic. These button batteries in particular can get stuck in the esophagus, especially of our younger children. If someone's older, then probably their esophagus is big enough for the button battery to pass through. But of course, who are the ones that are ingesting the random things in their environment? The 18-month-olds.
Right.
These button batteries will then sit there and will then discharge their current into the esophagus and can burn a hole through it, perforate, and even lead to death fairly rapidly within hours. So any ingestion of a button battery or suspected ingestion of a button battery is a medical emergency and needs an x-ray to see, one, did it get ingested in the first place? If it is ingested, is it in the esophagus? Or are we lucky and it passed down to the stomach where we don't expect it to cause problems?
So it's less of a problem if it passes through the esophagus.
Yeah, the big issue is it getting stuck between the two walls of the esophagus and then completing the circuit of that battery and then discharging all of that current, some leak of some alkaline contents, and that alkaline contents of that caustic materials burning through the esophagus and perforating. Of course, if it's not suspected, could be a super difficult diagnosis to
Sure.
make. The kid is refusing to eat, crying, fussy. And then if someone gets an x-ray and happens to catch it in the esophagus, you go, oh my goodness, now it's an emergency. You got to go and endoscopically and remove this.
Yeah. What about magnets? Yeah, those little teeny magnets seem a little less fashionable now than they were a couple of years ago.
Yeah, I think probably from some of these issues. So especially these rare earth magnets, buckyballs, lots of other brands out there of these super strong magnets that you can play with or like build something out of. The trouble is if multiple magnets were ingested, right? They're pretty tiny. And if you have multiple of those magnets ingested, they could end up on opposite sides of small bowel as it is there in the gut. And you could have a magnet on opposite sides. And those are so strong, they come and stick together and then perforate the small bowel or wherever in the intestines, leading to all those complications of peritonitis or potentially death and all the complications that would come with that. So if we ever have ingestion of more than a single magnet, our rule is to go in for an x-ray and see if we can see if there's more than one, hopefully two views, so we can make sure they're not just in line on one view and we can see from two different angles. And if those are there, either if they're in the stomach and accessible, have someone remove them endoscopically. If they've moved past the pylorus, then we have to see, do we electively just have surgery, go in and get those before they perf? Are they moving along? And are they together, therefore unlikely to catch on two sides? But if they're separated and they're past, so it's going to be consultation with pediatric surgery on do we need to go in and get these or just try to push them through with a bit of a bowel regimen.
Yeah, that sounds like no fun at all. Hydrocarbons?
Hydrocarbons, all sorts of things around the house are hydrocarbons. Probably the ones that are higher risk would be some furniture, polish oils. And then in the summertime, your like tiki torch, mosquito things, kerosene, stuff like that. These are hydrocarbons that can be very easily aspirated. A kid drinks them, and because their viscosity is so low, they just slip right down the trachea into the lungs, disrupt the surfactant, and cause substantial pulmonary injury, possibly leading to death, or I've had kids intubated or non-invasive ventilation for days with a severe pulmonary injury that comes from aspiration of a hydrocarbon. A lot of kids will just spit and choke as soon as they get these because they immediately start gagging on them. And so pretty quick, we were able to identify if a kid is symptomatic. If we hear that, we'll send them into an ER for some brief observation, maybe get an x-ray a few hours after the exposure to see if we see any blossoming of that sort of pneumonitis that's occurring. Most of the kids do all right, and they take a sip and just kind of sputter on it and are all right. But occasionally we do get a child who's very sick, ends up in PICU on some respiratory support.
And they can frequently look like the sorts of things that kids like to drink, like those really unnaturally colored things that kids drink.
Yeah, whatever color has been put there, they want to make something smell good as for some furniture polish. The labels are attractive, and that goes for all these different things around the house. If it's the tiki torch fluid that's there, everyone's out in the backyard having a little barbecue or something, and they went and filled that up, and now it's just left out where a child can get it.
Yeah. Which cleaning agents should we be most cautious about?
Well, there's a couple things that are very common, and there's a couple that are very dangerous. I think we have lots of common colored cleaners, right? They smell good. They may be bright red or blue or orange or green, and that just looks like some juice or Gatorade or sports drink or whatever else. And kids will get into those. A lot of these cleaners now are way more benign, and the things that are in them are not too bad. Of course, we always need to know what is that exact product so we can look up the safety data sheet and see what is in there. And is this something that's really bad and caustic? I'd have a list of a few things that are really concerning to me, and that's mostly the caustic chemicals around the house. The ones that you may not think of for that would be toilet bowl cleaners, can be really strong acids. Drain cleaners, of course, very strong bases, alkaline, Drano products, any of those. And oven cleaners are very caustic as well. Dishwasher detergent in particular can be pretty potent stuff. It can be a problem as well. Those would be the ones to really watch out for. There are so many brands with so many formulations that the answer for all of these is we got to figure out what it was and find the label and find out the exact ingredients and give us a call. And of course, many of these will be managed symptomatically. If a kid looks great, is eating and drinking just fine, has no lesions in the mouth or lips or anything else, then we might be okay. If there's any question at all, then our next steps would be endoscopy. Someone needs to go down there and take a look because maybe they swallowed it and the injury is just to the esophagus or the stomach and they didn't have too much on the lip. And so they'll lack of lesions on the lip or mouth doesn't rule out a more distal injury. So these are going to be consulting with your local endoscopist, whether that's Peds GI or whoever is doing those where you are, and then your poison center on how to take care of these. Those caustics are the ones that are the most dangerous. And then the most common are these brightly colored things that are left out. So the answer for all of these is make sure they're kept locked up and away. Of course, these are often under the cabinet or under the sink, which is a real easy place for a child to get to. So any sort of locks or devices you can have to keep it so the kids aren't getting into those in the first place, of course, is our best bet.
With the understanding that many of the things that we use slow kids down, but don't necessarily stop them.
Oh, right, right. Remember, these aren't child-proof caps and everything. Everything is a child-resistant cap. And one of those tests is to give it to a bunch of kids and see how long it takes them to open it. So
see if they can open it faster than I can.
yeah. And you're allowed a certain amount of time. It only has to delay them for, I'd have to pull up what the actual rule is, but it's not child proof, because if they were child proof, they'd end up being somewhat adult proof in one way or another too. So yeah, especially kids that are a little bit older, have pretty decent dexterity, or that cap wasn't closed all the way, they can still get into those.
Decent dexterity, a lot of impulsivity, and lots of determination.
Yes.
Yeah. Yeah. Super warfarins, I know we see those sometimes around mouse stuff.
Yeah, so super warfarins, right, were belong the thing in rodenticides. That sounds terrible, but what you do is just anticoagulating that poor little mouse so it ends up squeezing through tight spaces in your house and then bleeds to death, which is kind of gross to think about, but that's what they were. Those warfarins last an incredibly long time with half-lives on the order of a month or so, meaning someone could get very significant and prolonged anticoagulation. The really good news is the vast majority of the exploratory pediatric ingestions do not get anywhere near the toxic amount. Most of them end up being less than a milligram of any of those and not enough to cause any anticoagulation. And really, the only time we see that is with the suicide attempts where someone ate like an entire box of whatever one of these rodenticides is. Fortunately, now a lot of manufacturers have moved away from these rodenticides, but they've introduced some new products that we have less experience with. So what we talked about in our first episode of needing to collect data on the new agents, well, we've been doing that at the poison centers, and we're able to take care of most of these rodenticides at home. We have new products, cholecalciferol, vitamin D, that's in some of these, and fortunately, it's not enough to cause problems most of the time. And there's a new agent called bromethylene that's there that is unusual and is an uncoupler of oxidative phosphorylation in the brain, which sounds really bad, and it is. But fortunately, the dose that most kids get is quite low. And a lot of these products are now fancy, where it's a little device that the mouse has to crawl inside of it and then eat the bait and then crawl back out. And so you have to like pry it open with a screwdriver or something to try to get this out. And most kids can't get to it. So they've sequestered it away where it's not accessible to the child. So there are lots of different rodenticides on the market now. Fortunately, the amounts that most of our toddlers get into is not a toxic quantity.
One last category, and we touched on this last week, and those are things, ingestibles of various types, cannabis, tobacco, vape liquids, and alcohol. All those things can be an issue for kids.
Yeah, these are lots of things that our adults are consuming, right? And so they're often left out where the adults can get them, then the kids can get them as well. So many of these things are attractive to children in the way they're labeled and marketed to an adult that this looks like any other sort of candy. Let's talk about kind of each of those one by one. Cannabis. No matter where you are, there's probably some cannabis that's available for purchase. Most states have medical cannabis. A lot of them have recreational cannabis. If you border a recreational state, well, everyone's driving over the border to grab those. Here in Utah, we go to Nevada, we go to Arizona, we can go to Colorado. So there's plenty of it here and wherever you are. There's also the sort of gray market area of cannabis with hemp and the Farm Bill of 2018, where they made hemp legal. And what they did is they started taking all that CBD and turning it into analogs of THC. We're familiar with Delta 9 THC, but they turned it into Delta 10 or Delta 8. And it turns out this was actually entirely legal. Not what Congress intended when they passed that law, but that's why you may live in a state where there's no legal cannabis, yet you could see a vape shop where they're selling these Delta 8 THC products. So no matter where you are, there are probably some cannabis edibles available that the adults and teenagers will have. They're often in some sort of gummy or candy or chocolate product that may even be labeled to look like something like Nerds or Skittles or a Snickers or a Kit Kat or anything else. And it looks like candy. And so kids will get into it. and then get themselves a pretty walloping dose of cannabis.
And it also probably stands to reason, too, that both vape devices and vape liquids should be stored carefully.
Yeah, both of those two. I wanted to say one more thing on the cannabis here. I think everyone's getting used to this now, but if you have a kid who's brought in abnormally sleepy, ataxic, drowsy, and not really figuring anything out, get that urine drug screen. And when you see that come back for THC and the rest of your workup and evaluation is benign, then we're finding then after the fact, they'll say, oh yeah, there were some edibles, and oh yeah, I think maybe they might have gotten one. Parents are, of course, often hesitant to disclose that they had cannabis in the home. But I think more and more people are being comfortable with that. More and more of our folks in emergency departments are getting used to that. So keep that in mind for the otherwise benign appearing yet abnormally sedated child showing up to the ER.
Right. Well, I think we've just covered a whole lot of ground, and I'm hoping to retain a good portion of it. But I think the take-home message for me, and I hope all of our listeners, is: aren't we glad we have poison control centers? I mean, it's just so nice that we have that resource. When I say we, that we as a public, and also that we as pediatric providers, that we have a dependable place that we can get information from and refer people to.
Yeah, we've gone over so many different things here that can feel kind of dizzying of all these topics that we just barely touched on here. And this is the stuff that we do all the time. And so we're a resource for the public. We're a resource for pediatricians, and we're happy to chat about all of these things and figure out what do we need to do. I've said over and over, a lot of these are benign, but sometimes they're not. And we are more than happy to help anyone sort that out anytime, 24/7.
And for our listeners in Utah, poison control would be 1-800-222-1222. For our listeners in Philadelphia, the number would be 1-800-222-1222. For our listeners in Florida and everywhere else. What a great thing. That makes such a difference.
Yeah, it's so unique in medicine, right? There's no neurology center or cardiology center where you just call and get an instant consult anytime 24/7. Someone's awake. I guarantee you, every time you're calling the poison center, someone's already awake and expecting that call. So it should be the easiest consult you ever call.
All right. Well, thanks, Mike. I mean, this has been very helpful. Next week, we're going to talk about management and prevention. Given that next week, if you're listening in real time, is National Poison Prevention Week, we will talk to you again next week. Thanks again to our listeners. Please tell your friends about us, and we'll talk next week. Thanks, Mike.
Thank you.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Phil Wirkus, who composed the theme music. See you next time.